very good evening from India. I am Dr. Padmavathy Krishna Kumar. I very recently completed my undergraduate medical training from Karnataka in India. And I'm also a member of the Think and Do policy tank named Association for Socially Applicable Research, which is abbreviated as ASR. It is a think tank based out of Pune in India. So I would like to, in this webinar, I would like to present something about public-private partnership in alleviating healthcare facility access. I chose this topic purely based on my experiences during my hospital rotations the last 1 year. I feel I have some insights to share along with available literature on this topic. And I hope we can have a great discussion beyond this. And I hope this is of some use to all the viewers and all of those of you on the call. I'll start the presentation right away. Right. Okay, so before we get into the nuances of PPP, let us go into a bit of history. And before that, what exactly is a public-private partnership model? So you have multiple definitions in literature. The World Bank gives a different definition. I would say country-wise, there are different definitions. India and Peru do not have the same definition for public-private partnership. But the essence is what I have captured here. So it is basically a mutual agreement between two parties. The first party being the government of a country or at a provincial level, and a private entity. So basically, the mutual agreement is to provide services to a beneficiary by clearly demarcating the roles and responsibilities of both parties. PPP model is not exclusive to healthcare alone. In fact, it started off to fund infrastructural projects. Early 20th century in the USA. In USA, basically all the railroad projects and a lot of construction work were handed out to the private companies who took charge of financing right from the construction to operating the business. The healthcare aspect of a PPP model came much later, and it started around 1992 in the United Kingdom, where NHS was not functioning well enough, and that is when the government decided to consolidate and introduce something called as a private finance initiative, where they handed out existing government hospitals under the NHS to suitable private firms on a contractual basis. So the model followed was something called as a design, build, and operate, where existing facilities were handed over to private companies who basically were responsible, for revamping the healthcare sector there. So they worked on the infrastructure, and they decided how the hospital would function. They provided equipment like for diagnostic equipment and so on and so forth. So this was a very rudimentary model that was primarily started to ensure that the healthcare system in UK does not collapse. So gradually what happened was throughout the 2000s, this model gained momentum. It spread to Australia, and then slowly developing countries like low and middle income countries across all continents saw that there was some potential in using a PPP model in their healthcare sectors. So for example, in 2006, India constituted a specific national task force to oversee policy formulation and program implementation of the PPP model across the country. And a little earlier, in the year 1999, Spain introduced its first, constructed its first healthcare setup in the small town of Alzira. It was basically the government handing over a control to a private entity, and they were in charge of running the hospital from scratch. So we have a few, and the Alzira model was very successful, so much so that Spain eventually replicated the similar model across a few other districts in the country. And And in India also, we have a lot of PPP models. I will discuss a little more about each of its types subsequently. So I hope you get an idea of how the PPP model came into existence. So the next aspect is, so these are my references, right? So why should we, what is the need to discuss this? Why did I choose this topic? Like I said, I was inspired from my experiences, but let us view it from the lens of how it is going to create an impact in the overall healthcare improvement. So first one, we could view it in the context of global health. Now, so every country now has the PPP model, which is suited to how their country, the healthcare sector in their country functions. No two countries, although we have a common agreement, the primary healthcare service agreement, or the Alma-Ata Declaration, which is popularly well known. So we have an agreement that basic primary care has to be provided. So there is no clear, it need not be only the government alone. So recognizing the potential, PPP model was introduced to ensure that private entities, actively involve and revamp structures and help provide primary basic healthcare to its citizens. So now what happens is, the primary reason for choosing private entities to involve in public sectoral projects is mainly because, especially in the healthcare sector, as we all know, budget allocation is generally on the lower range. The OECD countries generally, like the countries with a higher GDP, like US, the UK, Germany, they all spend more than 10% of their GDP in healthcare. So they have strong public healthcare facilities in function because their spending is good. However, countries like India, China, Peru, our GDP spending in healthcare is on a very lower range. Like in the financial year 2023, India's GDP share of government expenditure for healthcare was just 2.2%, which is, by the way, considered an improvement from what it was in the financial year of 2019. It was just 1.6%. This is government expenditure alone. So, unfortunately, it is a harsh reality that GDP spending does not prioritize healthcare. Budgets do not prioritize healthcare, especially in low and middle income countries. So you can say that private entities have to be involved to scale up the quality of these services. So they private firms, they provide good infrastructure and manpower support. So this is why this is a predominant reason why countries resort to the PPP model in healthcare. The other context we can go look this view this PPP model discussion is along the lines of sustainability. This was explored by the Addis Ababa Action Agenda in 2015. They released a working paper in this working paper was released by the United Nations Department of Economic and Social Affairs. So they tried to link how having a PPP model can help achieve the sustainable developmental goals of pertaining to healthcare by the year 2030. Uh, Very unfortunately, they found that PPP model in healthcare has not been successfully implemented across all countries as was earlier thought. So what they say is PPP model can be good for infrastructural projects like railways, roadways, and other construction projects because private entities focus on profits. And these are projects that will gain private entities profits, so they are more eager to invest and recover the costs from it. However, services like healthcare or education are more on the social sector side. So you cannot exactly try to make it a for-profit industry. And the government, which usually offers all these services for free. You have free schooling, you have free healthcare provision at government hospitals, and government schools provide free education up to the age of 14. So these are a service to the society. You are empowering the people by providing them education or good quality healthcare. So when you view it in the lens of gaining profits, it could mean that not all private entities will be willing to actually invest in such a thing, because they are looking at max gain help them. So unfortunately, in view of sustainability, it has not been recommended to go ahead with the PPP model in healthcare. But we will again analyze the drawbacks of implementing PPT further in the presentation. And let us see what we can derive out of it. Moving on. Right. So my third, like I already mentioned a couple of times, my personal experiences with the PPT model have largely been positive. So the next few slides are purely anecdotal. So I studied at the Adi Chanchandgiri Institute of Medical Sciences, which is a private tertiary care hospital, and it is located at a rural area in Mandya district of Karnataka state. So within Mandya district, there is a small village called Bellur. And Bellur has its own community health center, which is a government setup providing, primary and secondary level care. So sometime around 2019, the government of Karnataka entered a joint agreement with our college, with my undergraduate institution. So it was the functioning of the CHC was completely handed over to my college. And under this agreement, so now our college has taken it over, and the Department of Preventive and Social Medicine took their responsibility very seriously, and right from providing a medical officer to the CHC, the current medical officer is Dr. Raghavendra, who is also a professor in the Department of Community Medicine at our college. So my hospital and the Department of Community Medicine together provided doctors, nurses, intern doctors, junior doctors like me, who had to go and work there from 9 to 5 for a stipulated time period. So they provided manpower support, they provided infrastructural support, and not just that, they also conduct regular health camps for the people in Bellur and surrounding villages. And they also conduct various educational camps, a photo of which I have attached here. So this is a few of my classmates who took part in the global hand washing day awareness at the CHC. They conducted a small program for it, where they taught people in the villages on the exact, the 7 steps of hand washing techniques, how it should be done, and things like that. Because these are small practices that our behavioral changes it, and it really impacts how the community's health becomes eventually in the long run. So they also conduct a lot of other awareness camps, like say a distribution of nutritious food kits to TB patients, and about reproductive rights. Like they conduct separate sessions for men and women on the different types of contraceptive methods they can use, and how to plan on family planning, and what is to be done if there is an unwanted pregnancy, or in case unfortunately they contract a sexually transmitted disease, how to seek care, how to prevent unwanted pregnancies, or any STDs transmission, and so on. So various initiatives have been taken by my college, and CHC Bellur in the last 5-6 years has drastically improved. And it was for me, while I worked here, I saw the change myself, and I was really proud that this collaboration actually was a success. So this is my first experience, and another experience with the PPP model in my own hospital is that our hospital also allows government schemes to be availed by the patients who are admitted. One such scheme is the Arogya Karnataka, which is a state government health scheme, which was introduced in March 2018. It was subsequently integrated with the central government's Ayushman Bharat insurance scheme, because both the schemes basically had the same kind of package offers. They covered the same kind of diseases. They provided same coverage amounts. So since instead of implementing it, two times, it was considered economically feasible to integrate the services. So now it is called, I have attached an image of the form here. This is what we get in our hospital. It is called the Ayushman Bharat Arogya Karnataka Pre-Authorization Request Form. So once a patient gets admitted, we ask them if they have any card. Usually a card is issued from Arogya Karnataka or Ayushman Bharat, for which they should have already processed it much beforehand. They should apply online and like they will get a certain card. So if they show the card, we will fill in this request form, and they will go and submit it to the insurance office located within the hospital premises. And within 24 hours, the scheme gets approved, and there is no out of pocket expenditure for the patient and the caregivers. So it is entirely reimbursed by the government right from admission to discharge. So this is, I would say, a very revolutionary experience for me, because to see that patients could just avail good quality care with no costs incurred was, I think, a brilliant move. And and even if patients didn't have this Ayushman Bharat or Arogya Karnataka scheme card, we made sure they got it done. So we would again anyway fill this form, and they would go and tell in the insurance office that, see, we do not have this card, but we heard that, there's a benefit behind having this. The insurance office will issue a letter, and this letter has to be submitted to their district government office, and the card will get approved. And whichever day of admission they get the card, it could be like the third or fourth day, from then the scheme is calculated. So until then, unfortunately, there will be an out of pocket expenditure, but from the day the scheme gets approved, it's all cashless completely. The hospital gets reimbursed later on after the patient discharges. But yes, so I have filled so many of these forms. I have myself spoken to a lot of patients and asked them to go ahead with, filing this, because it is good for them. They don't have to pay out of pocket a lot, and they can avail good quality care. They don't have to worry about. A lot of patients are unfortunately from rural areas, so I have seen patients wondering if they have to sell their homes to even, pay the ICU bills. And so for such patients, such schemes are like a ray of hope, and they get the benefits of both. They get benefited from the government scheme, and they get access to private good quality healthcare. So I think it is a win-win situation for the people, the government, and the private sector involved. And the next, moving on. So yes, so I have shared my experiences. I have shared what we know about PPP so far. Let us explore the different kind of models followed. Again, every literature will give you different terminologies. You will find something called as concessions. You'll find something called as franchisees. You will find something called as leasing out. So there are a lot of terminologies, but broadly you can divide PPP models in healthcare sector as greenfield projects and brownfield projects. Now, what is a greenfield project? A greenfield project is right from scratch. Uh, the private entity is given complete handover of the facility from the government. So they are told, you build this, you construct this center. It will be, we will fund you, we will provide you the resources, you construct it, you also arrange for infrastructural support and manpower. So the operations are entirely run by the public uh, private entity with some support from the public institutions in terms of financing. So there's a contract, there's a definite period for which how this should be done. But greenfield project is where the private entity completely manages everything from the start, right up to the regular functioning. So maybe for 5 years they are told, you run the whole thing, and then we will hand it over to another entity, or maybe we will take over after that. So there's some sort of a mutual agreement, and that's exactly how the Spain's Alzira model came into picture. A private entity right from the start has built it, and Alzira model, like I said, was very successful. And yeah, so that is the greenfield project. Brownfield project, meanwhile, is something like what the CHC Belur did. There's an existing structure, it needed revamping, and it was handed over to a private entity which revamped the structure, which revamped the facility. So brownfield is basically rehabilitating and developing a structure and that is already existing in order to provide better services. And another PPP model that I feel suits the Indian context a lot is, like I said, private hospitals, enrolling under the Ayushman Bharat or Arogya Karnataka scheme, which means that patients can get cashless hospitalization at private hospitals. So if they choose not to go to government hospitals, because government hospitals in India have a lot of waiting time, and as we all know, the care is comparatively of a lesser quality than that of a private hospital. So, so with more people willing to, opt for private hospital care, despite the risk of it being costly, I think it is a boon that such a model exists in India, where there's a government-based insurance scheme to assure them that no, you don't have to pay for any of this. You admit yourself in a private hospital, we will take care of your expenses. So this is a big boon in at least the Indian context. And the last model is leasing out of just infrastructural or diagnostic support to government hospitals. Like this is happening in Turkey, where say the private company is only responsible for providing equipment like X-ray machines, CT machines, or any other infrastructural requirement. So they don't focus on the uh, healthcare, the clinical service part of it. They are only given a certain contract to lease out infrastructural support. So this is for a specific time period based on their contract that they sign. And they are responsible right from providing to maintaining the facility. So if there's any issue, they have to step in and, pay from the private entity has to pay for repairing the machine, or, replacing it with a new model and things like that. So this is called as leasing out. So these are the four primary basic PPP models that I know about. Where I think I would specifically emphasize that greenfield and brownfield is the broader classification. Okay, so now let us move on to the debate versus bad of the private public partnership model in healthcare. Let's just start with positive factors. Let us talk about the benefits. So I think I've already discussed it in depth, so I will only be rounding it up with the main points. One is they bring in the required infrastructure, manpower, and diagnostic support. I have discussed this with a lot of examples already based on anecdotes, available literature. So that is one big advantage, that the government does not have to entirely put in too much investment. Only based on the contract, they have to provide the required resources and support, after which private entities will provide most of the infrastructure and manpower and so on. Point number two is additional revenue for hospitals through insurance schemes. Now, again, this is where again the government scheme comes into play. Like I said, private hospitals which are enrolled under the Ayushman Bharat scheme in India, for example, they get it completely reimbursed from the government. So these packages do not actually, they're not available for all diseases. So private hospitals also, they also have their own source of income through the regular, there are other services that they provide for which it is not covered under these schemes. And like usually they have other health insurance. Like a lot of us, we don't go through the government insurance schemes because it is for those who are from economically weaker sections. We all sign up for better health insurance plans, like paying a premium, and through that premium there is reimbursement. So they get revenue from such sources, from their main consultation fees, from their main diagnostic fees, along with private insurance company reimbursements, and along with that, government insurance schemes. Now that it has been introduced, it is just additional revenue. And there was a study conducted by Postgraduate Institute of India in sometime around 2022, where they cited that for government hospitals also, when they claim, when they claim for reimbursement, there first of all, government hospitals are totally funded by the state or the central government already. So along with that, when they claim, through Ayushman Bharat for the reimbursement for the expenses, they gain a lot of additional income. There was an analysis done by the PGI Institute, and they found that nearly per year at district hospitals, $26 million were earned through claiming of government schemes. This is just Ayushman Bharat. So you can imagine how useful the additional revenue is for government hospitals, who can then use it to just revamp their own existing structures. They can use it to procure drugs. They can use it to, increase the salaries of their employees. So there are so many benefits in terms of additional revenue, from the lens of additional revenue. And lastly, this is just anecdotal and a mix of literature at this point, is that perception. People obviously prefer private healthcare facilities these days. If given a choice between government and private, the thought process is, oh, private healthcare sector, it may be a little costly, but they at least, give like personalized attention to you. And, you get good quality medicines there. The doctors are very well spoken. The doctors, are they focus on your health and well-being. I think a lot of us obviously go to private hospitals in our own home countries. This is especially common in low and middle income countries. And so when you have such perceptions, right, and they get quick care, they don't have to wait for a long time at a queue. Like an average OPD in a government hospital in India sees about 2,000 patients per day. So imagine there's a person waiting to just get his BP checked. He has to wait for 3 hours. But in a private hospital, he can get that done in 10 minutes without any prior appointment also. So that is it. So people's perception, playing with people's perception is also one of the greatest benefits of the PPP model, because you're providing faster and better services and people put their full faith in private facilities, which can also be not exactly a good thing, because the public health system has to be very strong across all countries, because they provide it for free. They are supposed to provide better care, but unfortunately, it's not an ideal society, right? So we have people's perception being one of the biggest successes of the PPP model, right? So next, let's move on to the bad or the challenges behind implementing the PPP model. Now, PPP model is a mutual agreement between the government and the private entity. So what happens is there is something called as a risk sharing in the PPP model. So risk sharing is when understand that everything may not go according to the contract. So both parties should be willing to find a way to work around that risk. So, for example, one of the greatest risks could be that uh, the government entity is paying too much to the private sector to fund the project. And what happens is, now the private sector, like a lot of private companies, are profit minded. So they will try to milk profit, but this is unfortunately at the cost of a taxpayer's money. So there is no mechanism to regulate such things. So there's no mechanism to even regulate the performances of these PPP run centers. So you can have private companies charging like double the agreed rate between in the PPP agreement, and there is no way to track that because the government does not follow up regularly. And as a result, people are paying a lot more than what they're supposed to pay, which is unfair to the people and which is unfair to the government, because they have trusted this private entity to provide good quality services for a lower rate. So there is no mechanism to regulate the performance, or there is also, you can say, there is no way to regulate. There is a lot of risk factor involved. So that is one biggest challenge, and that is what the Addis Ababa agenda had identified. That because this is a social sector, this is a social service. Providing good health care is a social service. You should not do it in a profit-minded manner. But if you do it in a profit-minded manner, you do not get good quality services. And unfortunately, government-based packages cover only certain diseases or procedures. For example, you can get a hernioplasty procedure done even at a government hospital. But if you choose to go to a private hospital and get yourself admitted for the hernioplasty, you may not get Ayushman Bharat does not cover that, because their point is you can get it done in a private government hospital for almost free of cost. It was your decision to choose the private hospital. So unfortunately, there comes the factor of paying out of pocket. So out of pocket expenditures have continued to remain high. In India, in financial year 2019, Nearly 48.2% of out-of-pocket expenditure is still incurred by Indians, even though they have good access to government and private healthcare facilities. So why this out-of-pocket expenditure occurs is one, because for a lot of them, they do not have, like, people are in remote areas. So when you're in remote areas, you have to travel to a longer distance to access the nearest district hospital or even a good quality private clinic, like a famous private clinic. So there is a transportation charge that is involved for them, because you do not have immediate access to government run ambulances, or and the roads are also bad. Like in India, especially, roads are bad, and they have to arrange their own means of transport. So that is the cost. And they lose one, or like if it's a daily wage laborer who is traveling up to the main city from a village to just get one day, he has to spend one day to go and return. And again, there's a loss of wage for him, and he does not get paid because he's not working on that day. And he has to pay from his own pocket to, move to and fro from his village to the city and back. And sometimes, even in private hospitals, you do not have all the medicines available. So people are forced to buy medicines from pharmacies outside the hospital. So again, pharmacies charge a lot. These Again, pharmacy is a private entity. So in a government hospital, you'll get it for free. In private hospitals like mine, you will get good medicines at a subsidized rate. But once they're forced to buy from a pharmacy outside, it is a huge expense. And this is even more so for things like antibiotics, which are antibiotic injections, which are often given during long hospitalization stays for hospital infections. So this is also a harsh reality that despite the PPP model assuring good quality care at a low cost, there is significant out-of-pocket expenditures incurred. Lastly, lack of strong policy level commitment to enforce PPP functioning. So this happened in Italy during the early 2000s, where they did not have an understanding of how it should go. They just needed a way to revamp their health centers. So what Italy did is it spent nearly more than 50% of its health budget, and they gave it away to private entities, saying just revamp the structure, build, like, construct a hospital and run the, other than the clinical services that we'll take care of, you run the what is called as a light model, non-core services. So the non-core services included catering, laundry, everything else that is required to run a hospital other than the clinical aspect. So money was just given away, and as a result, PPP model implementation in Italy until almost 2010, starting from early 90s, failed considerably, because there was no assurance of proper return. There was no recovery of the costs put in by the private entity or government funding. There was no return. So eventually, because the policy was not well researched, there was no concept of going through a proper agreement of risk sharing and so on and so forth. So unfortunately, it failed. So that is why in 2016 onwards, a lot of research was done, and there was proper information sharing on risk management in PPP models. And that is why the first generation of PPP model is what failed in Italy. The second generation is ongoing implementation, and there is hope that it is better implemented, especially thanks to, because researchers and legal teams and consultancy firms stepped in to help Italian government to improve PPP model in a more structured way. Okay, so what is the way forward? We have different type models of PPP. We have discussed good and bad. So what is the way forward now? Are we going to abandon PPP model? No, because it is helping in ways we know or we may not know. The PPP model is helping, but effective PPP model implementation only comes into play with proper stakeholder involvement. So let me share a case that happened in the African country of Lesotho. So Lesotho had a 425 bedded tertiary care hospital constructed through a PPP model. And it was and initial studies hailed that as a hospital as a very good success, because in such a small impoverished country they were getting good quality healthcare services at a subsidized cost. That was what was initially understood. But eventually an Oxfam report in 2014 showed that no, Lesotho is already low. Lesotho was already spending less on its healthcare. The budget spending was very less, and added to that, nearly 51% of the health budget was going to fund just this one hospital, because they were paying the private company to run the hospital. So what happened was it was draining out future of Lesotho. So the model was hailed as a failure. So what could Lesotho government have done better? In this case, they could have had like a proper agreement that we will only fund so much percent from our budget to you. You have to put to the entity. They could have said, this is our sharing. You can use this funding along with your own ways of funding to run the hospital. But Lesotho unfortunately funded most of the running. So it was Oxfam even mentioned that had this been the old hospital that was purely government run, it would have been three times. It would have been run at a three times lesser cost than what was being paid to the private entity now. So you need again, the main underlying thing here is the agreement has to be perfect. It has to specify the contract period. It has to specify, government has to specify how much exactly they will be investing. Private companies have to mention how much exactly they will be investing and for what period they are willing to continue this contract up to. So first, agree. So like the fourth point, I think that is the key point here that everybody should focus on. That agreements between private entities and government to demarcate responsibilities must be very strong and very clear. So that and what happens is a lot of time governments do not follow up on how the center is doing, or they do not they cannot communicate with, as well as the private entities in terms of the legal issues that could spring up. So private entities can exploit this loophole, and they can say, no, no, we meant it this way, we said this in the contract, but we also meant it this way. And they can milk out more money and they can unfairly charge patients. So to prevent all this, a very neat and concise agreement has to be signed between government and private entities anytime they implement a PPP model, especially in healthcare, because we are dealing with lives of citizens, especially with focus on those from economically weaker sections. So the government private entities are equally responsible and accountable if the model fails. They should, just as they sign the agreement in hopes of providing good healthcare, they should at the same time be accountable to the risks incurred. So one is strong agreement between government and private sector. Another point I feel is also important is because scheme insurance scheme filing is a lot of paperwork for patients, for patients mainly. But in the hospital setup, it is the junior residents or the junior doctors who file the insurance paperwork for the patients. And this is in addition to the already clinical responsibilities that junior doctors and junior residents already have. So another key factor that should be considered is to hospital functioning and maintaining of digital records on how the hospital is functioning. The insurance scheme part of it should completely be outsourced by training and employing people just for this purpose. So they should be trained on how to record, like how to maintain a digital record of patient, right from the time they are admitted up to the discharge time. When did they file for insurance? And they should be responsible for educating and filing the insurance from the patient end. So this way, burdened, the doctors can only counsel, and after that, these people who are trained to maintain these records can take it further from there. So that is also a key point that can be done to ensure that one part of the PPP model functions well. When especially when it's a government scheme that's implemented in a private sector, I think this is a very important point, that we have specific people trained to guide patient and their caregivers on the various available schemes so that they do not incur any costs from their end. And there should also be a digital registry at provincial or local level and national level, specifically for PPP run hospitals to evaluate their performance. It could be something like they update online about how many admissions they had, and what was the fees charged, and how are the equipments running, where did the cost go. For example, maybe in 1 month, the private entity had to spend more on procuring some medicines, so that also should be entered. So the government should regularly track what is going on, so that if there is something they feel like something is off, they can always pull up the record and show and ask, where did the money for this go, where we gave you so much amount, how did you spend it, why is there a little, we gave you this much amount, but they can basically dig out the loopholes, and they have to, the private entity is accountable and answerable to the government if they have gone against or deviated from the agreement signed. They are answerable. So digital records are perfect legal documents that PPP model should definitely consider using. And one more thing is, digital records can also be manipulated very cleverly because people are growing tech savvy. So one more thing that the government should do is regular inspections should be conducted at PPP run centers. Like surprise inspections to see how the hospital is working, and if they're overcharging patients for services, if there are good quality drug stock, if the equipments are working fine, and things like that. Like you have health inspectors, right, who and you have food inspectors, for example, who suddenly turn up at restaurants, and they see how the food is being prepared, how they what sort of oil or what sort of ingredients are used to prepare the food, how is the food packaged or given to the customer. Similarly, health inspectors should be definitely given the power to, this is in lower and middle income countries especially, because there's a lot of loophole exploitation by private entities because the government does not follow up regularly. So following up from the government side must be taken more seriously, and it should be mentioned in the contract that we will have people coming and regularly checking your work. So to maintain records of what you're doing and what's going on. And again, contracts must be updated and renewed based on market rates. So this is to ensure that there's no breach of trust basically between the two parties. Like maybe the price to procure an equipment has increased, and the private entity, there's actually no price, but the private entity can claim more money from the government, saying actually the price for this equipment has increased, and we're switching over to buying from another company. So give us this much money. Now we don't know where the money will go. The government does not know where the money will go. The government will blindly trust and give. So there is a risk. Again, that is a risk factor. So in order to do that, contracts, government must, ask the private entities regularly to, give expenses, and based on market rates they can keep upgrading the contracts. They will know how much, if they have to give more money now or lesser money to fund these projects. So yes, so I think, and last point is obviously proper policy evaluation, like having, like how India has a separate national task force to oversee PPP policy formulation and implementation. It should be encouraged, and because the PPP model has great potential if implemented in the right way. So all that is needed is a robust policy that clearly states what the contract between a private and between the private entity and the government should be, how the contract should be framed. Like there should be a format for it, and there should be a clear digital record. Like the policy should mention and emphasize on having digital records at the hospital level. And yes, it's because ultimately the goal is to serve patients and ensure that they have a hassle-free, experience while availing healthcare. It is a basic right of every citizen in the country to get good quality care. So that process should be hassle. So end goal should be to provide good care to the patient. So I think these are a few points that I personally feel should help improve how the current PPP models function across, even in India or maybe across other LMICs. So we are nearly towards the end of the session. my end note would be that PPP models have potential. They will create good, meaningful impacts in the healthcare sector for the country. Like you will have, lesser mortality rates. You will have more healthier and happier people, and universal health coverage principles will be envisioned. Of providing good quality, acceptable, appropriate, timely, and affordable care if there is right kind of commitment from policymakers, private sector entities, and public health professionals and researchers. They should all work in unison to ensure that the PPP model is a huge success. So, with this, I come to the end of my talk. And before we wrap up, I would like to mention a little more about myself. I've already mentioned that I'm a recent medical graduate. So this is my campus, my undergraduate institution, Adi Chanchandgiri Institute of Medical Sciences. I've already mentioned it's in a rural area. It's a tertiary care hospital, so it caters to 5 districts in Karnataka. So our hospital is right bang in between a highway, and it is like the nodal center to provide healthcare facilities to 5 districts in Karnataka. So we have people coming from places that are 1 hour away, just because the quality of care is good and it is very affordable. We have super specialty services, we have the specialty services, and it is a teaching hospital. So there are doctors undergoing training. So it is a very good and well developed facility. And this is me working at CHC Belloor during my internship, and that is where I actually, and to me that was an eye opener on how the PPP model is a good success. So CHC Belloor has taught me a lot about how the government healthcare system functions and how a private entity stepping in can change things in a government setup. And my work with Association for Socially Applicable Research, I have worked on a lot of public health projects with ASER. ASER primarily focuses on analyzing, primarily in India, public health policies, how they can be improved better through scientific, they do systematic reviews. So I had the privilege of being a part of one such project called Indexing of Blood Banking Performance in India. We analyzed blood bank performance was ranked so far in India, and we suggested an alternative method to comprehensively evaluate a functioning of a blood bank. So we are saying what the government is doing now is not right. There is a better way to assess a blood bank's working, and we have proposed a way in our paper, and I hope you will all give it a read. Whoever's present on the call, whoever's eventually going to watch the YouTube video. So, I've written a blog for ASER's data story series, where we use government available data to analyze infectious disease outbreaks in India. So we basically try to understand how what do I say? How whether the data reporting by government centers is actually done accurately. So we assessed different sources, and basically this is a very short blog that explains that data collection can be improved by government health centers, and that is me hosting a podcast with Dr. Rucha Shete. ASER has its own podcast series also called Avaz, of which I am the lead, and I also get to host it. So I coordinate and ideate the session, and I also host it. This was my first podcast with Dr. Rucha Shete, who works in the mental health sector. Like she's a community medicine specialist, and she focuses on providing free mental health support services to the economically underprivileged community. And I have also been a part of a lot of virtual conferences, directly or indirectly. So this is me presenting a session at the Consortium of Universities Global Health Conference in 2022. I did a short abstract on how rabies program can be, national rabies program to reduce rabies incidents, how the program policies can be implemented better in India. So that was my presentation. And I also worked with Keppel Health Review. It was a public health magazine a digital magazine run by the students and alumni of London School of Hygiene and Tropical Medicine. I think everyone has heard of it. It is one of the top institutes for public health and tropical medicine courses. So I had the privilege of working with them for 1.5 years. Unfortunately, the magazine is no longer running, but I contributed a piece on Ayurveda to that to understand how indigenous health system and allopathic health systems can work in unison to provide better health care for its people, for the people of the country. So with this, we come to an actual end of the presentation. I thank Pegasus Institute and specifically Anukriti Nigam for giving me this opportunity. It is very early for me. I have just graduated, that too from an undergraduate course, but she put her full faith in me, and she also reviewed my presentation, suggested such important changes to make it what it is today. So thank you so much, Anukriti, for the opportunity. And I thank those of you who are present in the session, and those of you who will be watching the video, a subsequent video when it's uploaded on the YouTube channel. I thank you all for seeing the session, and I hope you take back something from this. And I hope you have a lot of points to reflect upon the PPP model. And I would love to hear back feedback from all of you, or if you have any questions or anything, please feel free to reach out to Pegasus team, and I can help. I will gladly help answer your questions. And I hope this fosters some sort of discussion on the PPP model. Thank you.